Okay. Hello. Uh, I welcome everybody to the final edition of 2025 of IASP's Partnerships for Life Global Initiative to Prevent Suicide bi-monthly webinar series. The Partnerships for Life is run by teams in the six WHO global regions, with the Western Pacific region split into two, along with the IASP Central Office. And this webinar today is co-hosted by me, Dr. Vikas Menon, on behalf of the regional team in the Southeast Asian region, and by Professor Paul Yip for Western Pacific Region 1. This webinar will run for around 1 hour, and there will be two presentations. The first one by Dr. Kamal Gautam of Nepal, which will be chaired by me, and the second presentation by Professor Ying-Yeh Chen of Taiwan, which will be chaired by Professor Paul Yip. Attendees, all of you were already given an opportunity to present questions to the presenters in advance, but all of you will have a further opportunity during the webinar by pressing the Q&A button on your screen. So I would encourage all of you to put your questions as you go along the webinar on the Q&A tab, and we will take them at the conclusion of each talk. We will aim to take as many questions as possible in the time we have. And as an additional information, the webinar will also be recorded and uploaded onto the IASP website. So once again, I welcome all the attendees for today's very interesting webinar session. And it is my pleasure to introduce presenter one, the first presentation by Dr. Kamal Gautam of Nepal. He is a psychiatrist and executive director at the Transcultural Psychosocial Organization Nepal. He is a clinical assistant professor at the Center for Global Mental Health Equity, Department of Psychiatry and Behavioral Health, the George Washington University, Washington, D.C., USA. And his presentation is titled Turning the Tide, Opportunities to Strengthen Suicide Prevention in Nepal. So once again, I remind attendees of the opportunity to add questions via the Q&A button on your screen. And now I invite Dr. Kamal Gautam for his presentation. Over to you, Kamal.
Thank you, Vikas, for giving me an opportunity to share my presentation. So as Dr. Vikas said, so I'll be presenting on the topic titled Turning the Tide, Opportunities to Strengthen Suicide Prevention in Nepal. So here are some pictures and snapshots from the World Suicide Prevention Day celebration organized by TPA Nepal in collaboration with the Ministry of Health and Population in Nepal. So when we look into the Nepalese context, like the current suicide rate stands at 25 per 100,000 population. And there are some typical peculiarities in Nepal, which seems to be quite different from those in other contexts. So while we look into the prevalence, there is greater prevalence among youth and young adults in Nepal. And if we look into the global male to female ratio in suicide, it's almost 4:1. But when we look into the ratio in Nepal, it's 1.51:1. So the ratio of male to female suicide is slightly lower than the reported prevalence. Similarly, the 6% of deaths in women of reproductive age is contributed by the suicide. So as demonstrated by the maternal mortality and morbidity study conducted in 2021 by the Ministry of Health and Population. And among the methods, so in case of completed suicide, hanging is the most common method adopted by people. And when you look into the attempts, so it's most commonly the pesticide poisoning that happens in context of Nepal. And as you can see in the graph, this is a linear graph showing the 10 years data on yearly suicide rates in Nepal, and it has been increasing every year. And suicide has also been a burgeoning issue among the migrant workers in Nepal. As we know, like remittance has become one of the major source of income and also the contributor to the gross domestic product of the country. So suicide seems to be one of the major causes among the leading causes of deaths among the migrant workers. So while we see it contributed to 11.4% of total deaths of Nepalese migrant workers between 2008 and 9 to 21-22. And this data seems to be reported in case of suicide, but when we look into the overall data, it's often believed that due to some complications, due to the reporting mechanisms, and also the compensation that the host country has to provide to the Nepalese migrants, so many of the times, uh, people are often like reported as having certain cardiac arrest and heart attack, and suicide is often concealed. So if you look into all this data, so it seems that suicide seems to be one of the major causes of death among the migrant workers living abroad. So there are a lot of factors which are ultimately contribute to suicide, because suicide is a complex phenomenon, as we all know. So it is contributed by biological, psychological, and social factors. And in countries like Nepal, often the social factors, social determinants play a significant role in leading to suicidal attempts and also deaths. So, as highlighted by the study conducted in 2011 and 13, so it's seen that younger age, the presence of mental disorder, especially the depressive illness, the marital conflicts, and also the family history of attempted suicide is a strong predictor of suicide. And interpersonal and family conflicts, the substance use disorders are also the key factors associated with suicidal attempt. In the other hand, stigma prevalent in the community and low mental literacy and often poor help-seeking behavior among people is also considered as one of the contributing factors to suicide. And as I recently showed in the last slide, so migration and fragmentation of the family, poor social support systems, and inability to seek help while people are abroad. So these are also one of the key factors leading to suicide. And gender-based violence, financial stress, and unemployment as are other underlying factors associated with suicide in Nepal. So having said this, so we often see a number of challenges and system gaps in suicide prevention in Nepal. So the first one that I would say is the data system. So there is a lack of comprehensive national suicide database and surveillance in Nepal. We do not have the national suicide registry, and like reports are being done by the police, and there is no health system data on the number of suicide attempts and also deaths. So this is a dissynchrony on the prevalence of suicide. And there is inadequate crisis response and post-pension services, though there is a helpline. So it's still not adequate to provide all these response, and the post-pension service is quite lacking. Besides that, like the means of suicide, especially the pesticides, ropes, and also various insecticides are commonly sold in the market, and these are freely available. So there is no adequate restriction policies at the implementation level. And a few suicide prevention efforts have been conducted by several non-government organizations. The consolidated effort and ownership by the government is still lacking. So that's another challenge for us. And while we say suicide is a complex phenomenon, it is a lot of multi-sectoral coordination and collaboration to intervene in suicide response. So, but there is a lack of synergy between the ministries, line agencies, and also the government and non-government organizations, and how to initiate the response and prevent suicide. Additionally, as I said, a lot of population is migrating to Gulf cooperation countries, especially, and also in the recent days to Europe, including the US, and almost it said like 7 to 8 million people are outside the country, and while these people migrate, so they suffer a number of mental conditions, and they do not get mental health and psychosocial services on time, and these are quite difficult to reach because they are outside the country, and due to language and other barriers they are not able to access services within the country, and they cannot seek services available in Nepal because they are already abroad. So these mechanisms have also caused challenges with suicide prevention. Besides that, prevailing stigma and discrimination on mental health and suicide, that's another factor. And the funding, it's a major issue because the government allocates very low budget, almost less than 2% of the total health budget to the mental health, so that's inadequate. Besides that, the current funding crisis which is going abroad, so this is causing a major hindrance with suicide prevention effort. And additionally, there is a poor accessibility to mental and psychosocial support services because these are not available across the country, and also mainly focus on certain urban areas where psychiatrists and psychologists are available. And there is a lack of focused effort, especially targeting the high-risk populations who are at risk of suicide. So these have posed challenges to suicide prevention in Nepal. However, we also see that there are a number of initiatives and efforts being undertaken by the government of Nepal, especially the Ministry of Health and Population. So if we see, the Ministry of Health and Population endorsed the National Mental Strategy and Action Plan in 2020, and it mainly aims to integrate the mental health into the primary healthcare system and also initiate suicide prevention efforts across the country. So this is already in place. Additionally, the government of Nepal, the Mental Hospital Lagan Ministry of Health and Population, and TPA Nepal, we initiated the National Suicide Prevention Helpline 1166, which is a four-digit number, and this is available 24/7. And people with suicidal attempt behavior or ideation, they can seek help from this helpline every day. And this is already running for the last 4.5 years. And lately the government, especially the epidemiology and disease control division of the Ministry of Health and Population, they published a media reporting guideline on suicide. So, and a few batches of training have been conducted to the journalists so that they can give a positive message, a positive reporting on suicide. So this has also been in place. And besides that, organizations like TPO Nepal have initiated community-based mass sensitization campaign. For example, the radio program, which is called Bache Sanchar Jitincha, means if you live, you are victorious, you win. So a number of episodes have been launched, and these have been raising awareness in the communities about suicide prevention and health seeking. A number of community psychosocial counselors have been mobilized in the community, and many of them have received the gatekeeper training on suicide. And lately, with the support of TPO Nepal, the Ministry of Social Development in Karnali province of Nepal, they endorsed the socio-emotional learning package developed jointly by UNICEF and WHO. So this package is being endorsed and they are planning to roll out. And besides that, TPO Nepal and UNICEF and also the government, we are planning to roll this socio-emotional learning package, which has been highlighted as one of the four major pillars by WHO Live Life approach. So this SEL package is being undertaken to roll out across the country starting from this year. So though there are a number of challenges, we see that there are a number of initiatives and efforts and also policies and strategies which facilitate the implementation of suicide prevention efforts in the country. And highlighting into the potential opportunities, I would first go with the National Action Plan Against Suicide. So the National Planning Commission of the government of Nepal, they have been drafting the National Action Plan Against Suicide because initially Nepal had no action plan against suicide and there was no consolidated program. And it's on the way to endorsement with technical assistance by TPO Nepal and WHO. So I believe with the endorsement of this policy, we'll have adequate funding and resource allocation on suicide prevention. And additionally, it would also enhance the collaboration between government, the non-government organizations, and also the private entities on mental health and suicide prevention. And additionally, I believe it will integrate the suicide prevention efforts across multi-sectors and multi-layers, not limiting to only the health ministry and not looking it as only a part of mental illness and consequence. The health, education, social, agricultural sector, home ministry, all sectors would come together and then we'll have a consolidated effort. So that's what this National Action Plan Against Suicide is aimed to contribute to. Second, I would say the Ministry of Health and Population is piloting the suicide registry in two of the districts in Nepal. So currently, like we do not have the harmonized data. The health system, they keep the record of the suicidal attempt, and then the police reports the completed suicide. But many of the times these are not synchronized, and we do not know the exact prevalence of suicide and suicidal behavior. So with this suicide registry, the government is trying to harmonize the data between the police system and health system so that we have a consolidated data on suicide. Additionally, as I said, the ministry is planning to roll out the social emotional learning package in schools. So from this year, so we'll be reaching, I think, almost more than 300, 400 schools this year. So with this social emotional learning skills, so the students are expected to uh, acquire certain pertinent skills to manage their emotions and also identify, then solve their problems, and also practice some major techniques which would prevent the mental conditions. Besides that, the Plant Quarantine and Pesticide Management Center of the Ministry of Agriculture, so they have also initiated efforts to pose restriction on certain means of suicide like the pesticides and insecticides. So they have strengthened their effort, but we are also trying to support them on what sort of pesticides are to be controlled and what pesticides should be available, because there is agriculture already ongoing. So with this, I hope with the collaboration with of the Ministry of Health and Population and Agriculture and the Plant Quarantine and Pesticide Management Center, we hope we'll be able to impose some of the restrictions among the highly lethal means of suicide, especially the pesticides. Additionally, uh, uh, um, while I said that we have the responsible media reporting on suicide being in place, but the government has not been able to roll it out. So we are trying to collaborate with the ministry to see if it can be rolled out to a large number of journalists across the country, especially working on media reporting, especially the newspaper, the online news portals, and also the certain radio networks. So I think there is a greater chance to do this because guideline is already in place. And besides that, since this 1166 four-digit helpline is based at mental hospital Lagankhel, we need to expand the services to every provinces, and so that a large number of people can access services at a time. Because in this helpline currently, like we can receive only 2 to 3 phones at a time. So if a large number of people call at the same time, we are not able to provide service. So there is a need to expand this helpline. So since this helpline is already in place, we are looking to scale up these across other provinces, and also see like if there could be certain digital support platforms, for example the tele mental health, if like people who are residing in the rural region of the country, or who are outside the country, they can still seek mental health and psychosocial support through the digital platform or tele health, and the tele mental health guideline is already being developed. So this will also facilitate the service delivery and also enhancing the referral pathways. Besides that, I also see a lot of potential opportunities on encouraging suicide-related research and its prevention. And currently, there are a number of research on suicide prevention in Nepal. So TPA Nepal is also collaborating with the University of Melbourne, and currently we are looking into the effects of media reporting on suicide, and we're also planning to see the intervention strategies and test or pilot this media reporting impact on suicide prevention. Lastly, what I would say is, as the WHO Live Life approach has highlighted, the capacity building of healthcare providers on task sharing approach and providing services to people with mental health conditions. This is quite essential. So we already have the WHO MS gap being adapted and contextualized in Nepal, and that has been endorsed by the Ministry of Health and Population. So allocating resource and also building the capacities of healthcare providers in primary healthcare setting, and then providing mental and psychosocial support services in the community at the reach of people will help preventing suicide and also responding to mental conditions on time. So there are a lot of opportunities on suicide prevention in Nepal. So we need to take it further. And if you have any queries, so this is my detail. You can send an email, or we can have Q&A session later. Thank you. With this, I would like to end my presentation.
Fabulous presentation, Dr. Kamal. It was fascinating to know the multi-pronged suicide prevention efforts that are already underway in Nepal, as well as plans to also expand and scale it up further. So we have our attendees today, but I'll just give them a couple of minutes maybe to post their Q&A in the box once again. I would encourage attendees to post any questions related to that you want to post to Dr. Kamal specifically right now in the Q&A tab, and I'll take it up. Right now, I do not see any questions there. So we did have some advanced questions that came before the webinar. So I'm going to pose some of them to Dr. Kamal now. Dr. Kamal, one of the participants has asked, what is the potential impact of legislative measures, such as, for example, what you mentioned, like the development of national strategies or policies, and of course, another problem in the Southeast Asian region which we face is about the decriminalization of suicide. So, what are your thoughts on the potential impact of these legislative measures on suicide rates in Nepal and maybe more broadly in the Southeast Asian region?
Yeah. Thank you, Vikas, for the question. So if we see like across the world, only like 36 nations, 37 nations have the National Suicide Prevention Action Plan. So in lack of this national level action plan, there is poor resource allocation and there is poor synchrony and also poor effort on suicide prevention and management in the country. So WHO highlights the need for national action plan against suicide as one of the key priorities for initiating response on suicide prevention. So I think legislation has a good impact. And besides that, if we see like if suicide is criminalized, so people often have the tendency to underreport suicide. People often do not seek help. So, for example, if a person who attempts suicide is being taken to the emergency department and that's being recorded as a criminalization, then he or she, while he or she is going through the distress and going through all these attempts, and he or she is put into the custody or inquired by the police, so that's often stigmatizing. So many times in the countries where the suicide is criminalized, and then most of the times there is underreporting and there is a greater difficulty in initiating suicide prevention response. So the first step towards suicide response is drafting and implementing the national action plan against suicide and also decriminalizing the suicide. So that's much needed effort in a region like Southeast Asia.
Right. Thank you so much for that, Dr. Kamal. There is one more question now by Professor Murad that is about the helpline that you mentioned. So he has asked what the statistics are for this helpline over the period of its existence so far, which I believe is about more than 4 years.
Yeah, so thank you for the question. If we see, I had the data of almost 3 years, and we handed over this helpline to the mental hospital under the Ministry of Health and Population, and we provided technical assistance for about 3 years. And during the tenure of 3 years, we had almost like 33,000 calls received over the helpline. So that's a huge number. And if we analyze the data, the timing and also the duration of call, so the calls seem to be more in the afternoon and the evening. And and people have many times we also receive the nuisance call and also people they do not speak. So for example, if a person is in distress and trying attempt, many times like we receive the silence call, they do not speak. So they have the suicidal ideation and thought in mind, but then they feel difficulty talking to the counselor, helpline counselor. So that is what we have seen. And many times if we do the social media boosting and campaign, there is a drastic rise in the trend of help-seeking behavior among people, and we receive overwhelmingly large number of calls during that time. So that's what we have seen in case of Nepal.
Fantastic, fantastic. So that's very insightful. So you did hint at some of the temporal patterns in the trends in helpline related calls. But Professor Paul has also asked whether there's any spatial pattern to the suicide rates in terms of within the country, Nepal, whether there is a difference in the socioeconomic status and situations which might predispose to this to the suicide rates. And he has also asked whether the Hindu religious beliefs or any religious beliefs for that matter can be leveraged as a protective factor or whatever support it can be for suicide prevention. So your thoughts on
Yeah.
that, Dr. Kamal?
Yeah, thank you for the question. So actually, it's interesting. So since I was given only 15 minutes, so I could not put all the data. So there is one publication from the Nepal police, and they did a rigorous longitudinal analysis of data, which shows that suicide rate is highest among the Dalit community. So it means the downtrodden, underprivileged community. So they have the highest rate of suicide, and besides that, it's highly prevalent among the LGBTQI population in Nepal. So that's most commonly seen. And besides that, is the suicide rate is more seen over the farming season, like harvesting season, while they use more pesticides. So, for example, the most common method of attempt in Nepal is poisoning. So that's often due to insecticide and pesticide, which are used during the farming, and the death from suicide is most often caused by rope. So, like which is like purchased by the farmers for their daily use. So during the harvesting season, the suicide rate seems to be quite higher than among other seasons.
Fantastic, fantastic. So that's again really insightful. A related question a participant has asked is whether what are the age trends and sex trends in suicide in Nepal?
So if we see, as I highlighted, the highest rate of suicide is among 15 to 39 years of age in Nepal. And as I said, the suicide rate is 1.51 is to 1 among male to female. So while we see globally, like the male to female completed suicide rate is often like 4 is to 1, but in case of Nepal, like it's almost near 1.5 is to 1, means the ratio is quite lower than that we would expect in other countries.
Yeah, that's true. For example, in India, the ratio is a little different. So that's again something very interesting. So I cannot see any more questions in the Q&A tab, and I'll probably end with one more advanced question. So this is I don't know. I'm not sure if you have expertise in this area, Dr. Kamal, but one of the participants has asked, what is the best practice in engaging those with lived experience and their caregivers at a primary care level? Any thoughts from your side would be massively appreciated.
Yes, thank you, Vikas. So actually, TP Nepal, we do a lot of work with people with lived experience of mental health conditions. And so we tried engaging like people with lived experience of mental conditions in the training under the resource titled Reshape, Reducing Stigma Among Healthcare Providers. And also during this operationalization of the National Suicide Prevention Helpline 1166, what we did was we built the capacity of some of the people who attempted suicide, who had suicidal attempt, who sought for help from our helpline, and then they build their capacities and then mobilize them on social media campaigns. So they came to the front with under the informed consent, and then we shoot up the brief video on how they went through. They put their narrative, like they went through the suicidal attempt and also their part of life, and how they were able to overcome their suicidal behavior over time, like seeking mental and psychosocial support, treatment, and counseling, and if they survive, it's a victory. So that's how we relay the positive message through them. And yeah, actually, while mobilizing those people with lived experience, this has a positive message, because as expert, while we say that you should seek help, but it's the people with their main like lived experience which matters the most. So their own perspectives on suicide prevention and help seeking has been immensely helpful, and they encourage help seeking behavior among people. And many times people say that I saw this video and then I attended your helpline, so that's what I came through. So there has been a good experience, and looking into their perspective and also engaging them on also drafting the national action plan against suicide in Nepal, so that we did, and they give a different perspective on how their things should be incorporated and how the intervention should be designed. So engaging these people, I think, is quite essential part of drafting the policy and suicide prevention response.
Thank you, Dr. Kamal. I think it's very important to know the direct and indirect benefits of incorporating insights from people with lived experience at all levels of suicide prevention, basically. So that's what your work also has shown. Once again, thank you for a very wonderful presentation, and we have exhausted the time given to our region. So now, but I would encourage participants to keep the questions coming in the Q&A tab, and we'll take them at the end of the second talk if time permits. So now I will hand over to Professor Paul for the second segment of today's webinar. Over to you, Professor Paul.
Yes, good afternoon. Thank you, Vikas. And our second presenters, I think, is Professor Ying-Yeh Chen. I think she is trained in Harvard, and she's an attending psychiatrist at the Taipei City Psychiatric City, the center, the Taipei City Hospital, and also she is a professor at the National Yaming Jiaotong University in Taiwan. And then she's going to talk about the impact of the Taiwan Suicide Prevention Act and interrupt time series analysis of the suicide rate from 2015 to 2023. I think the audience, I think would like to remind you, I think, to submit your questions while the Q&A button, I think, which will be taken from Ying-Yeh presentation. Professor Chen, please.
Yeah. Okay. Thank you for coming to this session. Okay. I'm going to talk about the impact of Taiwan's Suicide Prevention Act. Around the world, many countries have adopted national suicide prevention laws as part of a public health strategy. By having legislation in place, governments can secure stable funding, enhance cross-sector collaboration, and ensure long-term commitment to suicide prevention. And I want to briefly introduce the main types of laws that relate to suicide prevention around the world. First, criminal law. And we just have a question about the laws that criminalize suicide. In some countries, I think there are still 20-something countries, and especially those with strong religion or Islamic legal traditions, that attempted suicide is still treated as a criminal offense. But most countries, however, do not criminalize suicidal behavior. But many countries have laws that punish abetting or assisting suicide. A second kind of law is mental health law. And these laws allow compulsory treatment when someone is at very high risk of suicide. The third kind of laws are related to restriction of means, such as pesticide bans or gun control laws. And another important area is media reporting. Some countries, including Taiwan, have legal rules that require responsible reporting of suicide. And these laws may include fines for violation of reporting guidelines. Other laws related to suicide prevention are data protection laws. And this kind of laws, and because suicide-related information is very sensitive, so data protection laws set rules for how personal information is collected and stored and shared. And also the second area is science and technology regulation. And right now, a lot of countries are trying to figure out how to set rules for new tools, like using psychedelic in psychotherapy, using AI to detect suicide risk, or social media platform to catch harmful contents. And this kind of law, the idea is to encourage innovation, but still make sure these tools are used safely and ethically. Then there are some countries that have standalone suicide prevention acts. And this is today's topic. I'm going to talk about Taiwan. So this kind of standalone suicide prevention act provide a national framework for suicide prevention. And this kind of law usually define responsibilities and set long-term strategies and support cross-sector coordination. And these laws often include measures like mental health service coordination. This all means regulation, like paragraph bans, media reporting rules with penalties, and workplace stress protections, and economic safety measures. Overall, these laws aim to strengthen prevention and support, not to criminalize suicidal behavior. And based on our review up to 2025, September 2025, there are 10 countries that have standalone suicide prevention laws, including Taiwan. And in Australia and in US, there are just some province or some states have this kind of standalone suicide prevention law. So today I'm going to introduce the suicide prevention law in Taiwan. This is Taiwan, an island next to China. And this is a Taiwan at a glance. Taiwan is very populated island, 23 million people. And the capital city is Taipei, and Taiwan is highly urbanized. And the economy is heavily based on semiconductor and electronics. The GDP per capita GDP is about 34,000 USD and ranked the 25th. And as many of you may have known, we still have strong cross-strait tension with China. Okay. Taiwan Suicide Prevention Act was enacted in June 2019. And the aim is to establish a formal legal basis for nationwide suicide prevention and strengthen coordination between different groups. And I will introduce the elements of Suicide Prevention Act in Taiwan. So the act ensures dedicated resources for suicide prevention at both the central and the local level. And it requires the central government to run a 24-hour toll-free hotline. And local government must provide several types of support to suicide high-risk groups, such as psychological counseling, medical and psychiatric care, social welfare assistance, and employment support for people who attempted suicide and also to their families. This point shows that the Act focus strongly on services and support. And the laws also mandates the limiting access to lethal methods of suicide. And so the Act regulates suicide-related media content. So prohibits harmful or sensational reporting, requires the removal of violating content, and impose fines for non-compliance. The last key part of the Act is that it legalized the suicide attempter surveillance system. This suicide attempter surveillance program has been there for more than 10 years before the Act. And so we have the surveillance and then the aftercare program. And before the law, this system was there, but it was uneven and sometimes raised concerns about privacy and human rights. So by putting the system into law, we now have a clear framework for privacy protection and consistent national data collection, standardized follow-up care across regions, and stable funding. So overall, the Act makes the system more coordinated and more stable. So I'm going to report a study, and this study aimed to explore the changes in age, sex, and methods specific suicide rates before and after the Act. And we hypothesized that there might have stronger impact on younger individuals because the the element of the intervention, including regular media regulation and suicide attempter surveillance program, these are more relevant for younger people, as suicide attempters are more likely to be younger age groups, and younger age groups are also more likely to be affected by media reporting. And we hypothesize that more restrictable methods would have larger impact. And the methods we use monthly suicide rates, 4.5 years for the act and 4.5 years after the act. So we assess suicide rate from 2015 to 2023. And we assess 4 major suicide methods. These 4 methods, hanging, jumping, overdose, and charcoal burning, compose of more than 80% of suicide in Taiwan. And we categorized by 4 age groups. The study variable, we control for the COVID-19 restriction levels, unemployment rates, divorce rates, seasonality, and autocorrelation. And we use interrupted time series analysis. So this is the results. So this is the overall suicide rate. Before the intervention, it seems to be an increasing trend before the act. But after the intervention, there seems to be a slight decrease in suicide rates. So it's an immediate decrease, but the long-term trends, there's no change in long-term trends. This is total suicide rates. And when we look at men and women, the pattern is very similar. So before the intervention seemed to be a slight increase, especially in women. And after intervention, there is an immediate decrease, but the trend did not change. Okay. Then we stratify by suicide methods. This is hanging suicide, total, and by men, women. And these are adjusted IRR. So before, the hanging suicide was increasing, but after the intervention, there's an immediate decrease, and we also see a consistent trend decrease for hanging suicide. Actually, this is not expected because hanging suicide is not restrictable, and for men and women, the pattern was very similar. For jumping suicide, before the intervention seems to be a very slight increase. After intervention, no immediate change, but we still see an increase. So for jumping suicide, we see a consistent increase over time for men and women. Charcoal burning, there's no change in charcoal burning. So before the act, there's nothing there, it's flat. And after the act, it's still flat for both men and women. And for medication overdose, we didn't see any change before the intervention and after the intervention. By age groups, for the age group 15 to 24, the younger age groups, before the intervention, there is an increasing trend. There's marked increasing trend, but after the intervention, there seems to be stabilized. So there's no continuous increase after the act. And for men, not so prominent, but it is more prominent for women. So before the intervention, there's increasing trend, but afterward, it seemed to be stabilized. For the age group 25 to 44, there is no change after the act. So before it's kind of flat, after the act it's still flat. For 45 to 64, this is the major, and the age group that has the major change. So before the intervention, there's an increasing trend, but after the intervention, there is an immediate decrease and the consistent trend change, very slight, but a continuous decrease. And men and women is in the same similar trend, but it seems more prominent in men. But for older age groups, we see an increase, unfortunately. So before there's nothing there, but after we see an increasing trend for older age groups in both men and women, but women, the statistical significance, there was no statistical significance. Okay, so discussion. After the implementation of the act, the previous rising suicide rate trend stabilized, and a small immediate decline, and no major sex difference. Hanging suicide decreased the most, but jumping suicide increased. After the act, we see youth suicide rates stabilized. Middle-aged adults, 45 to 64 years old group declined, but older age groups increased. So how to explain this? Probably the immediate decrease, overall decrease might be a pre-act efforts and media attention and early initiative. Because before the act, we have a lot of meeting with the media personnel and to discuss about the change in laws or some coordination with the media personnel. And there might be some cultural change. And so the decline in hanging suicide was not related to the restriction of means, because hanging cannot be restricted, but it might be the enhanced help-seeking behavior. But the increase in jumping suicide rates might be related to the increase in numbers in high-rise building. For youth suicide stabilized after the act, but we worry about the older age adults that is increasing, and for some reason middle-aged adults the suicide rates decreased the most. Okay, there are some limitations. This is an ecological study, so we cannot infer individual level causality, and there might be some major confounding, and we did not know the detail or the quality of the intervention. We did not analyze the quality of the intervention in different places. Okay, so conclusion, we see a stabilization of the overall suicide rates after the act, and youth suicide rates leveled off, but jumping suicide rates increase and older age suicide rates increase. So this means that we need to continuous monitoring of the suicide after the act. Okay, acknowledgement, and this is our co-authors, and some slides were adapted from a previous presentation prepared by a co-author. And this is a paper published in Crisis. Thank you.
Thank you very much for the the presentation. I think we do have some question who has come in before. I think one thing they asked, have the suicide act in Taiwan, have they ever tried to involve those people who have lived experiences? I think in the formulation of this Suicide Prevention Act.
Because the legislation process is more about a public health approach, and it is initiated by the Suicide Prevention Center. And indeed, the Suicide Prevention Center was established in Taiwan for more than 10 years. Before the act, it was there for more than 10 years. And indeed, yes, I think through the more than 10 years experience, we have a lot of interviews with suicide attempters and their families, yes.
Okay. There's another question is coming in. Is say that, well, I think among all this, the new measure has been implemented. I think, is there anything missing? I think if you have a chance, I think you really have to do the Suicide Prevention Act. Is there anything missing among all this measure that you would like to see and that you think that it could be effective? I think to continuous to make a contribution, make a positive effect to reduce the suicide rate in Taiwan?
Thank you. It's a very challenging, and I think there are always something missing. But I think legal is just a backup. It's just a backing. It's not a. If you want to implement, there always something that you need to add it, such as we need more resources, and we need to integrate more. That we need to continuous monitoring, and maybe there are something new things happen that we need to integrate into the laws. For example, such as AI. These things is not written into laws, and we always have something new things coming in, and we need to revise.
There's another question. I mean, they say that in Australia, they just implement this sort of restriction of the time in social media. I mean, of the young people. I think from your perspective, what do you think about this? Or would it be useful, or whether it should be implemented in Taiwan? If it is going to be implemented in Taiwan, what do you think? How much resistance you might anticipate? I mean, when you're doing this in Taiwan.
Thank you. We have discussed this in Taiwan, but a lot of actually, I personally think it will be helpful to be restricted, because based on our survey, the more time you spend in the internet, and the higher internet addiction score, then it's related to higher suicidality. There are many studies on this, and yes, we are trying to do this, but it's almost impossible there in Taiwan.
Okay, is there any further question from the audience? Well, while we are waiting for the question, I think there's still a few questions I think we have received. I think they have mentioned about the charcoal burning suicide. It has been affecting Taiwan to quite a big extent. I think we also understand that in Taiwan have introduced some sort of restriction of means. Would you be able to update us what is the present situation, or whether it helps, or if it's going to help, and how it's going to do it better? Or is it, because we understand that, I mean, this charcoal burning suicide method has been spread, I think, to other countries as well. What sort of advice that you can give, I think, to the other places?
Yes, so at the high point in 2006, charcoal burning suicide accounted for almost 30% of suicide. But now charcoal burning suicide accounted for, I think, about 20 or 15 to 20, somewhere around here. And initially we used we follow Professor Paul Yep's suggestions. So we do some restriction of means. So we have the shop clerk to put the charcoal in a locked box. So you have to, when you want to purchase, you have to act them. But I think this has been enacted. This kind of measure has been widely practiced for a couple of years. But I think it's of 3 to 4 years. But then, so then during that period, the charcoal burning suicide rate decreased. But now nobody do this. So when you go to the shop in Taiwan, you can purchase charcoal in open shops. So for now, it's not. The restriction measure has gone away, because the law didn't say that you have to lock charcoal. Just say, oh, government have to restrict common suicide methods. So it's just a principle. There's no, so it's not strict rules that you have to follow. But but it's decreased and it's stay there. So we just didn't just try to make a media don't report the high-profile charcoal burning suicide. So I think we can do it from the media reporting, and when it is at a very high point, some restriction of means would help.
I think it will be. Would it be possible, I think, to put this restriction of means, I think, amongst one of the measures in this Suicide Prevention Act in Taiwan? I mean, when you try to make the act more responsive, I think more relevant, I think, to the local context. In your experiences, I mean, can you share with the audience, I mean, what sort of barriers? How can you get the politician, or how can you get the government people, or the health authority can buy in? I think for what you people have been suggesting.
And in the law, in the act, they just say it very principally. Just say government have to restrict lethal methods of suicide. But the law did not list every specific method that how to limit it. So it depends. Actually, it depends on the local government to see whether for charcoal burning, it depends on the local government. But for some national level thing like paraquat, there's a national ban on paraquat. So it depends on the legislation possibility.
Okay, there's a question coming in, and then they are asking whether in Taiwan, do you have any tools to measure the suicide ideation among the children and the adolescents? Do you have any tools that you are using in your daily practice, or you can recommend, that are very sensitive, good to differentiate, or to do this monitoring and surveillance, or this screening?
Okay, in clinical setting for the suicide risk assessment, we usually hope to do a more personalized, more individual assessment, rather to use a very common or one size screening questionnaire. But some institution did use some questionnaire. But I think you can just directly ask. Do you think about suicide? Yeah, just you can ask directly.
Okay. There's a question from Murad Khan, and then he is asking whether there's any lesson that Taiwan can learn from the decrease in suicide rate in mainland China. I think so. Is there any features that I think we can learn from one another? So I think.
You mean the decrease in suicide rates in China?
Yeah, in mainland China. Yeah.
I think suicide rates in China for now is very low, much lower than Taiwan, and but the changes in suicide rates in China is related to the urbanization, and I think in Taiwan in the 1980, 1990, 1970, we have the similar decrease when the rapid urbanization occurred. Yeah, so maybe urbanization and increase your availability of life opportunity may be a very important reason for suicide prevention and suicide risk reduction.
Thank you. So far, I think time's up. Do you have anything you'd like to say, Professor Chen? Do you have any final words or wisdom?
No, I'm good. Thank you for coming.
Okay. So first of all, we'd like to thank for both speakers, Kamal and Ying-Yeh, I think, for their presentation. I think, and we also welcome for all the audience, I think, who have participated in the discussion and then listening. And then it is from WPR1 and also from the WP for the Asian region. And then we would like to remind you the webinar has been recorded and then will be uploaded to the IASP website in due course. And then our next the webinars, the series will be scheduled on the 26th of February in 2026, and then will be hosted by the Eastern Mediterranean region. And then please keep an eye on it. I think if any audience members, I think, are interested in hearing more about the work in the IASP and PFO, and then please contact, I think, us. And then they are encouraged to subscribe to our newsletter, and then they're also welcome to become the members of the IASP. And then the details of this information will be available in the iasp.info. And then once again, I think we thank you, my colleague Vikas, and then to co-chair, I think, this meeting. And then hopefully, I think we all can learn from one another. So I think for Nepal, Taiwan, Hong Kong, and India, I think it really contributed to a lot of people to kill themselves already. So I think if we have to do something, Vikas, do you have anything to say?
No, I also want to thank both the speakers for a very insightful presentation. Thank you for sharing your work, Professor Chen and Dr. Kamal. And I'm sure this has given many new insights to attendees to carry on the work further. And any of the attendees want to pose further questions to the presenters, I'm sure they will be available over mail as well. And thank you, Paul, for the co-hosting this webinar. Thank you.
Yes. So, and then good evening, goodbye, or good afternoon, wherever you are. Okay. Bye-bye.
Bye-bye.
Bye.